We are
And we are
live. We're
live.
on the air. That's cool.
We're starting 1 minute early, so we're just getting a couple things rolling here. If you're watching us early, welcome to the live hangout for the Secret Language of Doctors. I'm here with Dr. Brian Goldman. We're going to get started. Well, it's 8 o'clock, so I guess we should get started. For those of you who already know, this is Dr. Brian Goldman. He's the author of The Secret Language of Doctors. And he's got some interesting stuff to talk about tonight. We're going to talk about the culture of modern medicine. Dr. Gold, why don't you tell us how your book's been doing and how things have been going for you the last couple of weeks?
Well, thanks, Brad, and thanks for being my live chat meister. Welcome to all of you. It's a pleasure to be talking to you at this Google Hangout in North America, and I guess maybe some places around the world as well. For those of you, I'm assuming you know me a little bit because of Twitter. My Twitter handle is NightShiftMD. I'm a staff emergency physician at Mount Sinai Hospital in Toronto, which is affiliated with the University of Toronto. For the last 7 years, I've been the host of a really cool show on CBC Radio 1 called White Coat Black Art. And that show explores the culture of modern medicine, and that's really what led me to write my book, my second book, The Secret Language of Doctors. My first book was called The Night Shift, and basically that was, hey, I have a copy of that here. I can flash that if you haven't seen it. Cool cover with who has a lot of stuff in a white coat, and that was a hour-by-hour account of what it's like to work in a busy emergency department, Mount Sinai Hospital. For my next book, for my second book, I decided to write this other book, The Secret Language of Doctors, because I love exploring and unpacking the culture of modern medicine, and I'm going to keep saying that many times. What I'm talking about is how doctors and nurses and pharmacists and paramedics and other health professionals get along with each other, what makes them excited, what makes them cranky, their rivalries, their jealousies, and what they really, really think about patients. And the reason I wanted to write The Secret Language of Doctors is that I believe that slang, hospital slang, which has this really fancy term called ARGOT, A-R-G-O-T, is a really cool way of very quickly understanding the culture of modern medicine. Now, is that important for you guys? You know, if you're a health professional, it's really important because we call that the hidden curriculum of medicine. That's what's really important, whether you're a resident or a medical student or an attending physician or surgeon, to get along with your colleagues and to work in a pressure cooker environment like a hospital. You know, whether it's in the operating room or the ER or the intensive care or the labor and delivery suite. For families and patients, it's even more critical to have this information because really, this is your first look at a deep dive into the system where I pull back the curtain and I reveal what really goes on in hospital culture these days. Important for you? Yeah. Your life's on the line. If you've got a loved one whose life is on the line, all really critical stuff for you to know about, you know, what kinds of patients health professionals love to treat, which ones they find frustrating, why they find them frustrating, and why they find certain situations frustrating. And when I was starting to do research on slang, I discovered that there were hundreds and hundreds of words that have been created to talk about patients that we find frustrating, situations we find frustrating, or difficult or challenging, and colleagues that we find frustrating. And I decided to put them all in one book, and I've kind of fashioned it as a tour through the hospital. And I think that once you read the book, you'll get up to speed, and you'll learn the slang, but more important, you'll learn about some of the most important issues that are facing healthcare today. If we want to keep healthcare doing what we want it to do for patients, then we really have to address some of these concerns. And I guess that's my little blurb about why I wrote the book, Brad.
Great. Well, listen, let's jump right into it. The reason why we're here tonight and why we're doing this live broadcast is because so many people have been asking questions about your book. You know, and I've got a list of them here. And as we're talking here, I'm watching the Twitter stream, and I'm seeing lots of people are talking about your book. And I see Tina Chu in the U.S. I'm hoping I'm pronouncing your name right. She's disappointed she can't get your book in the USA yet, so she's reading The Night Shift right now. She's enjoying it. We're getting a lot of people coming in over Twitter, so if you're watching this and you want your questions answered, tweet to Night Shift MD. That's Dr. Brian Goldman's Twitter account, and you can use the hashtag SecretMD. So that we can keep this conversation going after this call, and we're recording this on YouTube, so this will be an ongoing discussion that we have, and Dr. Goldman is very active on Twitter, so he's going to spend a lot of time responding, and he'll definitely see your questions as they come in. So if you want to ask questions live, I'm watching the Twitter stream now, so thank you to everybody who's tweeting us, Michelle Perron, Courage Sings, we're getting lots of different tweets coming in, which is great, so this is going to be an active call. I'm going to jump right into the first question, and this came from Patients Canada on Twitter. In your opinion, how can hospitals better deal with non-routine and ill-defined illnesses?
So that's a great question, and first of all, Patients Canada is an organization that I adore. A couple of years, 2 or 3 years ago, I had the pleasure of interviewing on my show White Coat Black Art Shalom Globerman, who's the president of Patients Canada. I also interviewed Elke Grenzer and the late Kevin Leonard, who all three former patients of the system who wanted to be better patients. The late Kevin Leonard, I want to take a moment to say that he taught me a lot. He passed away in the last little while after a long battle with Crohn's disease and complications about it. And I want to say that organizations like Patients Canada, and this is the preeminent organization that represents the patient experience in all aspects of healthcare, especially hospital care, but not restricted to hospital care. Why is that important? That's important because more often than not, at least until quite recently, healthcare was geared towards the doctor as the client, which is odd because the client ought to be the customer, which is the patient and their family. And I think patients and former patients have had that experience again and again where it seems as if the system is geared mainly towards meeting the needs of doctors, especially doctors, but healthcare professionals in general, and not the patients. So that's what Patients Canada is doing, bringing the patient agenda to everything, every aspect of healthcare, whether it's how you build a hospital, how you design it, the food, the things that we say to patients when we're taking care of them, whether it's in the emergency department or elsewhere, what we warn people about when we're warning patients about side effects. So now that background's really important. Back to the question that they posed. What's the approach to patients who have ill-defined or difficult conditions? Well, one of the reasons why I wanted to write this book, The Secret Language of Doctors, was to unpack some of the frustrations that health professionals feel when they're looking after patients who are chronically ill, often with either ill-defined conditions or with conditions that are difficult to treat, to cure. And that's important because the majority of the patients that we're seeing these days don't have a quick, crisp illness like a pneumonia or like congestive heart failure or a stroke where a carotid artery or a branch of an artery that's causing a stroke can be unblocked easily and you can just fix the problem. What we're seeing increasingly are more and more patients who have chronic conditions, and those conditions are not amenable to cure. They have to be managed, and they often require either close attention or especially more attention on prevention, on doing things to keep people out of the doctor's office. Now, why is that important? It's important because if we don't have the mechanism, if we don't have the right place, the right primary care, the right family doctor, the right family health team, health coaches, nurse practitioners, people providing the right advice and empowering patients to look after their own conditions, then they're going to keep visiting the hospital again and again for treatment. and they're going to get a reputation very quickly. And there's a slang term for that. It's one of the milder slang terms that I talk about in The Secret Language of Doctors, and that is frequent flyer. Frequent flyers are probably among the most numerous of patients that seem to tick off a lot of health professionals. The slang term frequent flyer is ironic. And there's a lot of slang terms in healthcare about patients that are ironic. In other words, they mean something very different from what the actual words mean. You know, in the airline industry, a frequent flyer is a beloved customer. But in medicine, a frequent flyer is often seen as somebody who keeps coming back again and again, and the doctors are saying, I got nothing more to offer this patient. Why do they keep coming back again and again? Well, what's important about that question and that whole issue is that we tend to blame the patient for coming back again and again. And there are some examples of patients who I document in the book, in The Secret Language of Doctors, who come back 300 times over a 4-year period. There are actual examples of that. And we can't resist the urge to blame the patient for coming back again and again, when the real problem is that they don't have the right place to go. And there are now some wonderful experiments that are looking at what can be done to provide a better level of care outside of the hospital for people who tend to come back to the hospital again and again. There's a more polite term for frequent flyer that was coined by Dr. Jeffrey Brenner in the United States. He calls them super utilizers. I like that one because it's more jargon and it doesn't blame the patient. But the thing that he's teaching is that if you provide excellent primary care, family medicine, comprehensive family medicine, not 10-minute appointments where they're just checking your blood pressure because that's what you had, or you stubbed your toe and they're treating that, but they're taking care of the whole picture. Your diet. Are you exercising well? Are you taking your medications? Do you even know how to take your medications? Have you picked them up from the pharmacy? Is there an issue there? Unpacking all those little things, and the end result is that patients are better looked after, it costs the system less money, and they end up visiting the hospital less and less and less. How do we fix that? Well, we have to have the will. We need better primary care, better family medicine. Whoever provides it, family doctor, health coach, nurse practitioner, registered nurse, or other scribe, case manager. They have different names, but the common denominator is that they spend the time helping patients manage their lives better, manage their health and wellness better, and all to the good, and they stop coming to the hospital again and again. Why? Because they're better looked after. And what I found, the other reason why I like this question, why it's so important, is that there's a common denominator to a lot of the slang that we use to describe so-called undesirable patients. And they're not just frequent flyers. They may be patients with chronic mental health issues, big issue these days. Chronic pain, addiction, patients who are elderly, patients with cognitive issues. The common denominator for many of them is that I don't think we've gotten good training in medical school to look after their needs. I don't think we recruit enough people who love looking after these kinds of patients. And here's the thing. These patients with chronic issues are becoming the majority of patients that we see, whether it's in the emergency department or the general internal medicine floors or walk-in clinics or what have you. And we better start loving those patients if we want to keep our jobs. And one of the things I want to be able to do by writing the book is highlight this issue, and also to say health professionals need to get outside their own heads and start empathizing with the patients that we're starting to see in increasing numbers.
All right, I'm going to keep going, Brian. We've got a whole bunch of questions coming in on Twitter here, so I want to just shout out to a couple people: Sherry Reynolds, Ian Wynn, Courage Sings, Alan Kay, our friend Alan Kay is watching, Michelle Perrone. So this question comes from Courage Sings on Twitter, and the question is, does language have the chance to negatively affect culture and ultimately patient care?
In my opinion, language, first and foremost, represents the culture that is. So I want to make that really clear, because a lot of people have been asking that, a variation of the question that you're asking. Fundamentally, I believe that slang or argot is not the problem so much as a symptom of a bigger problem, and lack of respect for the kinds of patients we see, lack of empathy. Sometimes it's lack of training. If you don't have good training in managing frail seniors with urinary tract infections who develop toxic delirium, in other words, they become acutely confused and start to hallucinate, something that a 40-year-old might not do, then you're going to find treating those patients frustrating. And the answer to that is to get more training. Sometimes it's, in the case of morbidly obese patients or bariatric patients, it's not having the right equipment. So I don't believe that the language changes behavior, with one exception. If you have a purveyor of slang who disrespects patients and uses slang that disrespects patients, then it won't surprise me at all to have their acolytes, their residents who are learning at their footsteps, their senior medical students, their nurses, allied health professionals, adopting the same slang, but really that's a symptom of the fact that they're adopting the same attitudes. So in my way of thinking, the slang's not the problem. Other than I want to make one thing really clear: slang that disrespects patients and disrespects colleagues is something that I don't encourage. I don't like it, and if I ever hear somebody doing it, I pull them aside. But I don't think that the slang is the problem any more than eradicating the slang will solve the problem. The issue is, are there fundamental issues that are making it frustrating for a group of health professionals, or one health professional in particular, to look after certain kinds of patients? Or is there a purveyor, somebody who is kind of providing a negative influence, and that is influencing others who is disrespecting patients, for instance, and is in fact influencing others, younger people, to disrespect as well. That's the root problem. That's the one that needs to be fixed, not the language. In fact, I would listen for the language because I want to be able to hear and monitor if there are issues in the local culture of medicine that need to be addressed.
Great. I'm going to move on. There's so many coming in here. Alan K, it's Alan KAY1 on Twitter. If you want to follow him, he's got some great updates to follow on Twitter. Alan says, the book is great. How do we change the culture of medicine?
Changing the culture of medicine is one of the most difficult things to do. And you know, I've often likened the culture of medicine to being as strong as the strongest immune system. It will send out antibodies. Anybody who comes in with a new idea, it's going to send out antibodies to try to fight it. I did a TED talk when I talked about my own medical errors, and one of the things I talked about in that TED talk is that we find it difficult as individuals to talk about our mistakes and to share them candidly, and to receive support when we make mistakes. And that's because we tend to internalize from a very early stage of our training a deep-seated shame about the mistakes that we make. I hate that because, in fact, failing, I don't invite it, I don't want it to happen, but the best thing that we can do with a mistake is learn and grow from it and share what we've learned and grown, and that our learnings and our growth with our colleagues. But we don't do enough of that. Now that's starting to change. We don't do enough of that. So that's one of the cultures that needs to be changed. And I had a fascinating visit quite recently with Dr. John Toussaint. Dr. John Toussaint was the former CEO of an amazing hospital chain in the United States called ThedaCare. ThedaCare is based in Appleton, Wisconsin, not far from Milwaukee. And this is one of the first clinics, one of the first hospital systems in North America to adopt lean principles borrowed from the Toyota production system. And I know you're starting to think, people aren't cars. What can cars and assembly lines teach us about how to practice medicine, how to take care of patients? Well, it turns out they can teach us a lot. I'm not going to say more about that. You're just going to have to listen to a brand new season of White Coat Black Art this coming fall, starting in September, for you to learn more about that. But the interesting thing is that they have a whole system there. It is based on things like identifying problems, not sweeping them under the rug, but identifying them and enjoying each problem, because each problem is an opportunity to find a solution. I find a lot of healthcare cultures don't look for problems. They don't want to know about problems because problems are a hassle to them. Whereas problems, challenges to Theta Care are their bread and butter. And Dr. John Toussaint, the CEO, he was the guy who was the CEO of the hospital, and what drove him crazy was how the hospital could do wonderful work caring for one patient one day, the next day there could be a near disaster or an actual disaster, and he wondered, why aren't we better at standardizing this? And he set out to standardize the procedures for everything from taking a history to when to order an x-ray, you know, how to put a central venous catheter in, and how to transfer a patient from one floor to another, how to prevent patients from falling, and there are literally thousands and thousands of these protocols that have been developed. So I had a chat with Dr. John Toussaint, and you know, we reflected upon the fact that many hospitals, not as many hospitals have many are starting to adopt lean principles, but they pick and choose. They don't adopt the entire method, which was actually taught by an American named Denton, who couldn't convince his American colleagues to adopt lean in American industry, to adopt lean principles. So he went over to Japan, taught Japan Inc., and the rest is history. You know, Toyota and other corporations there adopted lean principles and profited immensely. You know, Toyota went from being a car with a bad reputation to having the best reputation. Of course, it fell on hard times recently, and why? Because they abandoned lean principles in favor of a growth strategy. Now they've switched back to lean, and they're starting to do better again. But Toussaint told me that many hospitals are reluctant to change the culture, the local culture. And there are many reasons why that's the case. I think hospital administration might be afraid of surrendering some of their control to people on the front lines of medicine, and that's an important principle of lean management of patients. That when you surrender control, when you're in at the top of the food chain of the administration of the hospital, if you surrender control to the people at the local level, guess what? They know their own problems, they know what they need to fix, and most of the time they're able to fix it, and they only escalate up several levels if necessary if they're having trouble solving a problem. Changing that culture is one of the great challenges of the 21st century. It's a slow and steady process. Toussaint is very optimistic. I'm not so optimistic. You know, I find that some of the things that I'm espousing, both in the book, in my TED Talk, things like being open and honest about mistakes, really honest about them, honest to the point of being vulnerable, not being I'm the all-seeing, all-knowing doctor, but vulnerable. That is a really difficult row to hoe. I wouldn't be doing this if I wasn't fighting to change the culture of medicine. If you guys have better ideas on how to do it, I want to hear them. I am impressed that Toussaint, he thinks that the most important thing that he can do at this stage of his career is to meet with senior executives of hospitals, not teach lean, but teach the senior executives of other hospitals how to adopt lean principles. Over to you, Brad.
A quick follow-up question to that. Do you think that these changes are going to happen faster in the United States or in Canada?
I think that's a really interesting question. I think that that American healthcare right now is far more nimble than Canada for a number of reasons. Off the top of my head, the main one is that I think that across Canada, because we are next door to the United States, we are very defensive about our healthcare system. That means that we're defensive and we're very vigilant to attacks coming from the United States, and there have been many of them recently, you know, looking at the Canadian healthcare system, publicly funded, and saying, look at all the mistakes they make, their outcomes are not as good as ours, and we tend to get defensive about that. And when you're defensive about the system in which you work, the last thing you want to do is change it. So, and you know, if you're looking at innovation, yeah, there are pockets of innovation across Canada, but there's much more innovation, cutting-edge innovation, and it's no accident that for a new season of White Coat Black Art, I've visited the United States because I think there's some really neat, interesting experiments in changing the cost curve, inverting the services that we provide, putting the money in the right place to be able to get better outcomes at a lower cost. And you know, I think they're more interested in having value for the money that's spent in the United States. I think they're more likely to see the patient as the customer rather than seeing doctors as the customers. And so I look for innovation to occur in the United States. Now, all that said, a lot of the beginning of the Affordable Care Act and Obamacare has been a mess. Everybody knows that, and time will tell, you know, whether that's a success or a failure. Who knows? You know, is it here to stay, or will it survive a Republican administration if that ever happens, or a Tea Party administration if that ever happens in the future?
All right, I'm going to keep going here. So we have a question on Twitter. The tweets are just pouring in. Jeremy, I hope I get your name right. Jeremy Kuiman. His question is, will healthcare ever approach the level of efficiency and customization of chain restaurants?
That's a great question. That's an article. That's the kind of thing that Atul Gawande has written about in the New Yorker and broadcast on PBS. I think, to me, lean is the closest to that model, and what I mean by that is that almost any procedure that we do in medicine can be standardized. Duh. Why is that important? It's important because in a chaotic environment like the emergency department, there's a tendency to make things up as you go along, and it happens all the time. I've been watching it for more than 25 years, long enough to know that that's often what happens. And there are attempts to standardize in a haphazard kind of way. The standardization of procedures, you know, in other words, if I'm talking to a resident and the resident's telling me about a patient that I'm in charge of, I'm supervising, they're my eyes and ears, can we standardize the communication about how they present the history and the physical so that and is there a place where we can do it? Should it be a quiet place? Should it be in front of the computer monitor so we can look at all the lab tests? You can standardize all of that. You can standardize how you transfer patients from the ambulance stretcher to the gurney in the emergency department, or how you insert a central line, how you deliver a medication, and so all of that can be standardized. What's really, really interesting is that healthcare was slow to adopt standardization, and it's no accident. The most recent studies suggest that in the United States, 400,000 people die every year of preventable harm that could have been prevented. And so there should be an awfully strong impetus to fix it. Certainly John Toussaint at ThedaCare believes that standardization is the way to do it. Not just standardization, because standardization of procedures doesn't work if it's imposed from the top down, has to come from the bottom up. So I think we can do it, but it's going to require a lot of work. And yeah, sometimes you're going to have some wiggle room for variation. For instance, the emergency department is more chaotic than other wards in the hospital, should be a lot more chaotic, should be a lot less chaotic in the operating room. And we've seen early data that shows that checklists, surgical checklists, can make a difference. I think we need to see a lot more of that. Will it ever reach the standard of food chains? Why don't you get back to me in about 30 years, and we'll revisit that question again. I guess I'm kind of saying I doubt it.
I look forward to walking into the hospital and seeing a menu board. Okay, so this one came in via email. Why should patients and their families, people who aren't doctors and nurses, take an interest in your book and the issues that you're raising?
Well, they should take an interest in my book because, well, for one thing, we have an aging population, and that means that you're either going to be bringing a grandmother or a grandfather or a mother or a father or a partner, an aunt, an uncle, somebody beloved to you to the hospital. And you can assume they're going to be well looked after and not listen to what's going on, or you can listen to what's going on and learn things that might help you be a better patient or a family member, or in the worst case scenario, know, for instance, that the health professionals that are looking after your loved one are frustrated, and one of the things that happens when there's frustration is that you get withdrawal. And if you've ever had the experience of kind of knowing that a mistake has taken place but nobody's talking to you because the walls have gone up and they start to avoid eye contact, you know what I'm talking about. I've had a lot of people who have suggested to me that maybe it'd be better if the secret language of doctors stays secret. And I say, no, I don't believe that for a minute. I think you want to know. Now, why slang? Slang teaches you in very short order. It unpacks very quickly what health professionals are feeling, what they're thinking. I think if they say frequent flyer, it's probably said with a little bit of contempt or maybe a bit of frustration. So if you get the sense that your loved one's being identified as a frequent flyer, then you can begin to ask the question, is there a better place for my loved one to go? And that might lead to some solutions. I think that there are several undercurrents that I talk about in the book, several themes that I think are absolutely essential for patients and families. One of them is medical futility. Medical futility means that the doctors and the nurses believe that providing a certain kind of care or a certain level of care is futile, meaning that the best care provided, the most expensive care, by the smartest people with the best equipment, will do nothing to restore your loved one, that patient, to a level of quality of life anything like they had before. And when that happens, health professionals don't want to deliver that care, and so if they are gently encouraging a family to sign a form that is sometimes called the do not resuscitate form or a do not attempt resuscitate. Sometimes it's called an AND form, which stands for allow a natural death, which is what happens to people. And the family doesn't want to do it because they feel like they're playing God. Well, that's the moment when the health professionals are thinking this is really futile, and they get frustrated. Do you want to know about that? Yeah, I think you do want to know about it, because if you have a different idea, if you want a better level of care, then maybe you should be asking for a second opinion. And that's one possible answer. Another possible answer is that instead of patients and their families being kind of frightened by the whole experience on the one side, and on the other side of the gurney, you've got health professionals who are frustrated, maybe the slang is a signal that they need to talk to each other. And if they do talk to each other, then they can actually achieve a meeting of the minds. That happens. Fortunately, that happens more often than not. I think that families, by learning about this sense of frustration, may start to have that first inkling, that first moment when they start to think about the end of life. And we have an aging population, and with an aging population, it's no accident that issues related to how we want to die are starting to go mainstream. There's a whole debate going on across the United States and across Canada over euthanasia, over issues related to, if our loved one's heart stops, do we want everything to be done, or do we want nothing to be done? Do we want comfort measures only? And these are issues that I talk about at length in the book, in the Secret Language of Doctors. So that's another thing that I think we need another reason for looking at the book. I explore ageism in the book. I explore the difficulty, the antipathy that is sometimes exhibited towards patients with chronic psychiatric illnesses, particularly people with borderline personality disorder, chronic depression. And sometimes I've seen not only not only frustration, but it borders on contempt. And you know, whether you can do something about it or not, I think you should know about it, because knowing about it will make you a better patient, a smarter family member, a smarter health consumer.
All right, keep on here. If you're and you haven't had a chance to yet, you can tweet NightShiftMD, and you can also use the hashtag SecretMD if you want your questions answered live while we're doing this call. We're on here for another maybe 20-25 minutes here with Dr. Brian Goldman, the author of The Secret Language of Doctors. Brian, we're going to keep going. I've got a bunch more to ask you. A lot of these came in. We took questions via email. We're taking them live over Twitter. We'll sort of put you to the top of the list. This one came in over email. How do patients make a difference in all of this?
That's the fundamental question. And you know, one of the themes that we talk about, one I talk about in the book, and what we talk about in the corridors of hospitals, is that all of us tend to be in silos. That means that the emergency doctors and nurses are practicing in their world and aren't really aware of what's going on the wards, on the general internal medicine wards. Very often the people in the intensive care unit don't have an awareness of what's going on in the emergency department. The people in the operating room don't have a clear sense of what goes on the general medical wards. In addition to that, it's even more true that patients are in a silo that's separate and distinct from the health professionals looking after them. And yeah, I mean, we look after patients, we examine them, you know, we order tests, but very often we aren't including the patient and their family in discussions. You know, sometimes it's even more fundamental than that. We have difficulty empathizing with patients and the patient experience. And as a result, we're missing, first of all, we're not forging a solid relationship with patients and their families. The second thing is we're missing details in their history that could save their lives and could make it a lot easier for us to come to a correct diagnosis, which is fundamentally one of the most important things that we do, or provide the best course of treatment. And so we have, in my opinion, have in the past systematically excluded patients from the discussion. So, you know, for instance, it would be the usual procedure for one doctor to hand over to another. You can't have doctors, you can't have nurses working 24/7 all the time. And so, you know, one shift of nurses would hand over to another. The nighttime doctor would hand over to the daytime doctor, and the daytime doctor at the end of the day at sign-over rounds would hand over at 6 p.m. to the doctor working nights, and so on and so forth. Most of the time, those discussions would take place out of earshot, away from the patient. What we're starting to see is that smart hospitals are turning that around by having that handover experience occurring right at the patient's bedside, right beside the family and the patient. Why? So that, first of all, family members know the information, can hear the information that's being shared, and can correct it. So that you might have a nurse, you know, giving a report on the patient's status as he or she hands over to the next shift and saying, you know, Mr. Smith is taking enalapril for high blood pressure. And then the daughter says, no, he's not. The doctor stopped that 2 weeks ago. Oh, and the information gets corrected. And this becomes a valuable conduit of information. But to accept that, you have to have a mindset to say patients are not the enemy, and that patients and their families, in fact, are our best friends. And I can give you so many other examples of that. What I'm talking about is a movement in hospitals called patient engagement. And that means putting the patient where they belong and the family where they belong, front and center, in managing their own care, in guiding and being an active participant in their own care. And there are so many different examples of that. You know, one of the ones that I love because it matters to me emotionally. I have, you know, my father passed away 6 months ago, 7 months ago now. My mother, and he was in and out of hospital in the 3 years before he died. My mother has advanced Alzheimer's disease, and she's been in and out of hospital. She lives in a long-term care facility. And so, not as just as a physician, but as a son, as a brother, my sister and I have been at the bedside many, many times, and we have a lot of experience as family members, as loved ones to our parents. And so there are many initiatives that I've seen that bring the patient experience into focus. One of the ones that I love the most is something that we're starting to see in intensive care units and other parts of the hospital, where they're getting rid of the concept of visiting hours. You know, the big sign in the hospital that says visiting hours are, you know, between 11 a.m. and 8 p.m., something like that, and the rest of the time you're excluded. What they're doing at some of these enlightened hospitals that believe in patient engagement is knocking out the word hours and leaving the word visiting, as in just visiting. In other words, if you're a loved one, you can visit whenever you darn well please, because, you know, it might be helpful. Maybe your loved one has moderate Alzheimer's disease and sundowns. That means that they sleep all day and they're more active all night, and maybe you can be helpful as a loved one to visit your loved one at night in the hospital instead of going home to sleep, if that's what you want to do. Or in the critical care unit, in the intensive care unit, if you've got a loved one whose life is hanging in the balance and you want to visit whenever you want, you should be able to do so. In fact, a very smart and wise critical care specialist who we've had on White Coat Black Art, her name is Susan Shaw. You should check out her Twitter feed, check out her blog. She's one of the smartest docs I know. She said to me, wouldn't it be nice if we treated family members as, well, we tend to treat family members as the visitors. What if we treated the doctors and nurses looking after the patient as the visitors? Because that's who the visitors really are. We visit in the lives of our patients for a short period of time and then we're gone. It's the family members who are part of the story and part of the team, part of the family for the rest of their loved one's life. So getting the patient into focus, it means empathizing with them and fundamentally joining their struggle, because their struggle is our struggle to make things better for them. And it's, you know, I guess when we're frustrated, when we're tired, when we're sleep deprived, it's very easy to see patients as the problem. They're not. They're the solution.
All right, I'm going to move on to the next question. This one came in from an email. Some doctors have said that this slang is not actually in use. Are they in denial, or are they just feeling guilty?
You have to ask them to get an answer. I've certainly heard that, and I will acknowledge freely that there are cultures, there are subcultures where they don't use slang. In fact, read the book. I interviewed people that eschew slang. Kathy Grichnik, who's an anesthesiologist at Duke University, you know, top 10 hospital in the United States, she has worked, and there's a lot of slang for anesthesiologists, you know, in some hospitals that they have for surgeons, and surgeons for anesthesiologists. There's a little bit of there can be in some operating rooms there can be tension between the two. She doesn't use the slang. Instead, she gets to know the surgeon she works with. She loves them. By getting to know them, what's she doing? She's breaking down the silo. She's empathizing with them. That's perfect. So if you're lucky enough to practice in a culture with a really wholesome environment where people value each other, maybe because they've walked a mile in each other's shoes, they, you know, maybe there are places in rural areas where they depend on each other so much, and they socialize with each other that they get to know each other. Maybe it doesn't happen. That said, I interviewed hundreds of residents, attendings, nurses, paramedics, other allied health professionals throughout North America, and I can tell you that slang is alive and well in many different environments, probably because it reflects a lot of the frustrations that I've talked about and others that you'll just have to read about in the book. But no, the slang exists. It's interesting. I think some of the early media attention focused on glossaries of really horrible words like cockroach, or that old historical term FLK, which stands for funny looking kid, an odious phrase that used to be used maybe 20, 25, 30 years ago that was slang for a child born with a genetic abnormality or a series of genetic abnormalities. If you read the book, you'll see I put that slang in for the historical reference, not to say that it's an active word being used today. That said, there are pejorative words used that have been invented in the here and now. Many of them describe morbidly obese or bariatric patients. Phrases like whales, seals, referring to patients by a certain trope. How many clinic units they weigh, where one clinic unit is 200 pounds. So if you say that somebody's 3 clinic units, you're saying that they weigh 600 pounds, and you can say it within earshot of the patient, and they don't know what you're talking about. So pejorative slang in certain cultures exists. In some cases, it's because of frustration. The frustration with morbidly obese patients is real. Not to blame the patient, but to say that if your hospital doesn't have the right equipment to lift them, the right equipment, an operating room table or a stretcher that can carry the weight of a 600 or 700 pound patient, or a wheelchair that can carry them, then you're going to find work in that hospital when you're taking care of ill patients who are morbidly obese, very frustrating. But in that case, the slang should point us to the fact that there's a problem, a systemic problem that needs to be fixed. And so my answer to the people who say the slang doesn't exist, maybe you're lucky, maybe it isn't in your environment, maybe you've got the right leaders, maybe you've got the right key opinion leaders or people, mentors, and that's wonderful. I wish we could, well, hey, if my book is the beginning of the end of slang, I don't think I'd be sorry about that at all. But remember, this is not just a book about slang. It's a book about the problems in healthcare. And my sense is that even those who would never use slang still feel frustration with things like medical futility, dealing with an increasing number of patients who they either feel they don't have the right training, the right equipment, or the right inclination to treat. And so there are problems in the system that we have to fix through better education, better equipment, and more appropriate recruitment of the right kind of people who love looking after patients who are increasingly in the majority.
Let's talk about something different for a second, because you used a term earlier on that just kind of glossed over, and I think a lot of people may have never heard this term before, and I actually just learned this term recently, health coach. In fact, we've met a mutual friend, Z-Dog MD, out in Las Vegas, who's doing some cool things. A lot of people who are watching this probably have never heard this term before. What is a health coach?
Health coaches are an astonishing new advance in healthcare. I used to think, like a lot of other people, that health coaches were simply fitness gurus that taught people how to exercise right, how to stretch, maybe how to do some yoga, how to ramp up their exercise routine, and how to eat right, maybe a little bit about how to cook right, how to buy the right foods. What I discovered from Z-Dog MD, Dr. Zubin Damania, who is working at a really cool place called Turntable Health, he's the director at Turntable Health, what he is doing and what others are doing is bringing health coaches in to play a much bigger role in looking after patients. So it goes something like this. These are people who work alongside often family doctors, but they may work alongside internists or cardiologists or others. Family doctor says, you've got high blood pressure to a patient. Here's type 2 diabetes. Here's your metformin. That's the medication. Here's glyburide, another medication for diabetes. Here's Coversil, a medication for your high blood pressure. And quickly writes a script and says, well, by the way, you should lose 10 or 15 pounds, and we'll see you in 8 weeks. Well, and then they leave the room, they book an appointment, and maybe it's 3 weeks, maybe it's probably, let's be more realistic, it's 3 months later. 3 months later they come in, they haven't taken their medications properly, they have gained 5 pounds, they haven't lost 10 pounds, they're not exercising more. And so there's been this growing recognition that physicians like me can set goals, but we're really lousy in helping patients achieve goals, and we give patients advice, but we're not good at getting them to take our advice because we don't unpack the things that need to be done in order to get them to be able to follow our advice. That's where the health coach fits in. Health coaches, yes, they might help design an exercise routine, but more than that, they'll actually have a visit where they actually go for a walk with the patient. And you can learn a lot of things by going for a walk with a patient. I saw that. When you're the health coach who walks alongside a patient, you can have a conversation, and soon you can see, are they out of breath? You can listen for the sound of breathing distress. Are they getting sweaty, or are they in good shape? And so, you know, you can see, or you can also see the way they walk. Is there an issue with the way they walk? Is it their footwear? So you can actually help them figure out how to exercise better. You can go to the supermarket with them if you're a health coach. If they are a patient, and this is the really cool thing, that doctor I told you about, that family doctor, writes a prescription for 3 months worth of medications for diabetes and high blood pressure and says, bye, see you in 3 months. What does the health coach do? They call in 24 or 48 hours and say, how are you doing? Do you have your meds yet? And the patient says, no. And that's the moment when the health coach kicks in and starts to unpack some of the reasons why they might not have filled out their prescription. All of the reasons. Maybe they didn't understand the prescription. Maybe they didn't know where they had to get it filled. Maybe they have maybe it's a language barrier issue. Maybe they didn't have the money to pay for it, to pay either for the drug, or if you're from the United States or Quebec, the copay, you know, the added money you have to pay for it. Maybe they've got the pills, but they were put into bottles when they needed to be put into blister packs, or other compliance measures that make it easier for people to take medications. It's the job of the health coach, no matter what that job is, to get the patient from that first moment when they leave the doctor's office in tip-top shape for when they go back for the follow-up appointment. And health coaches have been shown to improve the health of patients. How? You take that type 2 diabetes patient, and because their diabetes is better managed, they come back to the office, their hemoglobin A1C is perfect, and they don't go on to develop eye problems or kidney problems or heart problems or strokes that would ensue from poorly managed diabetes, which is the scourge and the bane of 21st century North American existence, Western existence. A good health coach is part coach, part motivator, part case manager, part advocate, part family member, articulate, problem-solving family member that you wish you had. And if you want to bend the cost curve of primary medicine so that you can actually have a healthier population, better looked after, fewer complications, fewer visits to hospital, and check it out, fewer frequent flyers, hire health coaches, and fewer doctors. You'll actually be able to take better care of patients with fewer doctors. And I'm not trying to eradicate physicians from the business of healthcare. I want them to practice at the top of their scope of practice, not at the bottom, and I want them to get much better results, and this is the way that they're going to get better results. I'm so glad you asked me about health coaches, Brad.
So if I'm watching this and I'm still new to all of this, this sounds so new. How do I find a health coach?
There are some in the United States. You want to find a clinic that has health coaches, and more of them have it. In Canada, that's a problem because, and this is one of my bugbears, in a publicly funded system that will provide pretty decent cancer care, take out your cancer. If you've got an acute stroke, give you a clot-busting drug, do an angioplasty faster than your head spins, at least in many parts of Canada. Hip replacements, knee replacements, MRIs, cataracts. What do the provinces pay for preventive medicine? Zero. Nothing. That's bad news. And because the provinces pay nothing, now I know they do screening programs, but because they don't provide preventive medicine, that is what allows entrepreneurs working at private for-profit clinics in Canada to charge rich clients $2,000 to $3,000 or $4,000 per year, maybe a little bump up more for the whole family, and in return for that, they will provide unlimited access to a basket of treatments and professionals not covered by the provincial health plan. And some of them are health coaches. And they're hiring a lot of health coaches to provide that kind of tender, loving care attention that I was talking about. And that's a problem. Well, hiring health coaches in that environment, that's not the problem. But we need to hire those. We need to steal those health coaches away from private clinics and put them into a publicly funded system so that we can all benefit from them. I've certainly talked about that on CBC before, on the Canadian Broadcasting Corporation, White Coat Black Art, and I'll continue to advocate for that in the future. So really the short answer to your question, Brad, is that if you want a health coach, you probably have to go to one of those concierge medicine clinics, you know, the ones that provide this sort of unlimited access to the basket of treatments I was talking about, when we really should be advocating for them to be provided free of charge to everybody, including and especially kids. You know, one of the best ways that we can have a healthier population is to teach health education, how to eat right, how to exercise right to kids, along with reading, writing, and arithmetic. Make it a fundamental life skill and start early if we really want to have a healthier population.
Awesome. Well, listen, you know, we're getting towards the end of this, and just at the end, we start talking about health coaches, and Twitter is blowing up. Everybody is impressed with the idea of health coaches. To a lot of people, this is a very new concept. In the last couple of minutes, are there any other solutions that you want to kind of share with us that are on the cutting edge, like Lean, like health coaches? I mean, you've talked about some really cool stuff that's happening. Is there anything else that's on the horizon that we should be watching for?
Yeah, you know, I think there's a risky kind of thing that's being done at innovative clinics in North America, particularly the United States, that has to do with the health coach concept, and that is, they call it bending the cost curve. Basically, they're doubling down on primary care. That means more health coaches, more time for family doctors and nurse practitioners to look after patients. You know, in the United States right now, they spend about 4% of their budget of the entire healthcare expenditures on primary care, family medicine, and the rest is on that expensive, high-tech hospital medicine. And what some of these enlightened clinics and medical chains are doing in the United States is doubling down on primary care. So instead of 4% of expenditures on primary care, they're doubling it to 8%, and so the rest. And they're reducing the amount spent in hospitals from 96% down to 92%. Now, that's not a high-tech toy, but it is a cutting-edge concept, and it's really important. And if this works in the United States, and we're already starting to see some preliminary evidence that you can take the sickest patients in the system in the United States and double up their primary care, family doctors, health coaches, nurse practitioners, what have you, more time to address those chronic diseases, they end up costing less money, and they're not as sick, and they don't visit the hospital as often. So it's a win-win-win. Obviously, that would involve taking money out of the acute care system. Well, so what? You know, healthcare has to evolve just like every system has to evolve. I don't think there's anything wrong with that. You know, I would say that the other major innovation that I'm seeing is putting more power in the hands of patients, more power for self-diagnosis and self-management through apps, and in many cases, these are apps that can do things like obviously check your blood sugar and blood pressure. That's old hat, but sending a signal to a central database, giving you instructions on how to manage, or maybe the instructions go to your doctor. There's also cool apps that are available for physicians. For instance, you know, obstetricians can now monitor the fetal heart monitoring strips of their patients who are in labor, who are waiting to find out if they're going to have a vaginal birth or a cesarean birth, and the fetal heart monitoring can be sent automatically through an app to the obstetrician's smartphone across the street from the hospital, across town, across the continent, or around the world. And so there are going to be apps that are going to benefit doctors, but I think the big innovation will be self-management. And why do I think that's important? Because you have a motivated patient managing their own health, enlightened, educated, with access to their own data. And I got to have a shout out for my friend and fellow Twitter buddy, ePatient Dave DeBronckhart, who's been on our show on White Coat Black Heart and goes all around the world teaching how important it is to let patients have control of their own data so they can manage their own health. That's going to be the other major innovation we're going to see in the years to come.
Awesome. Well, listen, I want to say thank you to everybody who came out and asked questions on Twitter and via email. You definitely helped to make this Hangout a success. We appreciate the opportunity to interact with you. And Dr. Brian Goldman, I want to thank you for spending the hour with us. It's been enlightening. I think a lot of people have learned a lot of cool things about what's coming next and about you and what you want to do to change all of this culture of medicine. I think it's really cool. Hold up a copy of your book. We want to plug the book one more time. You can get the book on Amazon.com or Amazon.ca right now. So if you're in the U.S. and you want to get a copy of the book, you can go to Amazon.ca and order it. You'll pay a little extra for shipping, or you can click on the Kindle version and you can get that on Amazon.ca, and it'll still instantly download to your Kindle device. So if you can't get it in the U.S. yet, hopefully it'll be available soon. But for now, you can still get it through Amazon.ca. Thank you, Dr. Goldman. We appreciate you spending the hour with us.
And thanks for being a great MC, Brad. And stay safe, stay healthy out there.
Night.
Bye now.